So first up, for this session, we've got Hanna Oltean, hope I'm pronouncing that correctly, from the Office of Communicable Disease Epidemiology, Washington State Department of Health. Hi. Make sure you're speaking right into the mic so the web conference will be great.
Hi, good morning, everyone. It's always a pleasure to come up north to this conference. Let's see. So today I'm going to talk about Hantavirus in Washington State. It looks like from a quick perusal of the BCCDC website, you guys also have a couple of cases a year up here, so hopefully this will be relevant to some of you. I'll quickly go over a background on Hantavirus, some risk factors for transmission, and discuss the epidemiology in Washington State and in the US nationally. So we know that hantaviruses are part of the bunyavirus family, and they primarily exist in rodent reservoirs. There are both Old World and New World hantaviruses. Old World hantaviruses called hemorrhagic fever with renal syndrome, and New World hantaviruses called mainly hantavirus pulmonary syndrome, or HPS, which is what I'll be talking about today. So we know that in Washington State, the causative agent of all historical cases of hantavirus that have been identified and reported is Zoonoses virus. The reservoir is the deer mouse, or Paramiscus maniculatus. That's the only reservoir known in Washington. And we know that infected deer mice shed the virus in their urine, saliva, and feces. The virus doesn't cause illness in the rodent reservoir, and so you cannot tell if a mouse is infected by looking at it. And we know that favorable environmental conditions might increase transmission among rodent populations and to people. Humans mainly become infected when they inhale the virus from the environment, and other animal species may be infected as well. There's a little diagram there on the bottom of mice in the environment and a person sweeping. So in Washington State, there were some past efforts to look at infected rates in the mouse species. So between 1993 and 2002, about 1,100 deer mice were captured and tested by serology. On average, 14% were positive across Washington State. But this did vary greatly by county and area, and the sampling methods also varied greatly. So some areas were sampled more heavily than others. Some areas had sampling only around known cases, and so that could obviously affect the percent positive. Regardless, we know that hantavirus is endemic in Washington State, so it exists in our mouse population. So we generally assume if a person has contact with a deer mouse to presume that that mouse is infected. We've also learned that the infection rates in mice and rodent density are not sufficient for understanding risk of human infection. There are very complicated mechanisms both within rodent populations and between rodents and humans that predict whether or not a human becomes infected, and so that's a very difficult thing to predict when and where a case is going to occur. So as I mentioned, Zoonoses virus transmission occurs mainly when contaminated air is inhaled, although it can also occur when virus-contaminated objects are touched, so through fomite transmission, or if a person is bitten by an infected rodent. And there is no person-to-person transmission of Zoonoses virus that has been documented. We know that people living and working in rural areas are at very high risk compared to the rest of the population, and obviously people who come into contact with rodents. So this largely occurs when rodent infestation occurs in and around the home. And a 2017 EID article noted that case patients most commonly report their rodent exposures at home. So the main primary methods of prevention involve avoiding rodent contact and taking precaution if you are in contact with rodents or with their environments. So preventive measures to keep rodents out of the home, like sealing up places for rodents to enter the home, cleaning up food, trapping rodents that exist, and then using only wet methods for cleaning up rodent nests. So as far as clinical presentation, the prodrome for hantavirus pulmonary syndrome is very nonspecific, so it looks just like a viral illness. That's followed in a very rapid time frame by ARDS and thrombocytopenia. There has been documentation of non-HPS and Nombre virus infection during the 2012 Yosemite cluster. And during this outbreak, 2 out of 10 cases that were identified had mild illness. One just had fairly mild respiratory symptoms, and one had fairly mild GI symptoms. But to the best of our knowledge, the predominant presentation of Nombre virus infection is HPS, and the only cases identified in Washington have been HPS so far. So serology is the most common method for diagnosis. We have tests available for both IgM and IgG. And both of these, both IgM and IgG, develop very rapidly. So by the time someone is a day or 2 into the prodrome, you would expect to see IgM and IgG present. We know that cross-reactivity between different hantavirus species can occur. And false positives are possible with a commercial assay, and I'll talk about this a little bit more later. There is also a PCR test that's available. It is specific for Nombre, but it's not very sensitive in that viremia can be brief. And then we also know that there are other laboratory findings that are very sensitive and specific for hantavirus. So for example, thrombocytopenia is 98% sensitive for hantavirus. So there really is no treatment other than supportive care. And essentially, a patient with known hantavirus should be transferred as soon as possible to a tertiary care hospital that has ECMO capabilities. So this is a look at the epidemiology nationally in the United States. You can see that it's predominantly a disease of the West, and Washington is the 5th highest reporter of hantavirus in the US. Predominant cases are among people of middle age and among men. There have been a large number of cases reported from American Indians, predominantly in the Southwest. And this is a look at our epidemiology in Washington. This is by county of exposure, and this is not adjusted by county population. So you can see we have quite a few cases that have been reported from the center of the state, and some of these counties have very small populations. We also see a predominance of cases among men and among people of middle age. Our race data is not complete enough to do a great analysis on race or ethnicity, but we do see 36% fatality among cases, and that's consistent with what is seen nationally. This is a look at our cases reported by year, both nationally and in Washington. So on the left is the cases reported nationally, so you can see that we have about 1/10 of all of the cases reported nationally are reported from Washington. And in 2017, we saw the 2nd highest number of cases ever reported, with 5 cases reported so far this year, and 3 of those were deaths. When we look seasonally at these cases, again on the left is national data, and you can see that there is this nicer bell curve when you look nationally, versus in Washington State, we seem to have not nearly as smooth of a curve. So it appears that we have a peak in March, again in the midsummer, and then maybe something going on in the fall. So it's unclear at this point if this is just really small numbers or if we really do have different seasonality than what is seen nationally. So I want to talk specifically about a small cluster of cases that were seen late 2016, early 2017 in King County. King County is the county that contains Seattle, and so just east of Seattle, we saw a cluster of 3 hantavirus cases. You probably can't see the dates on the bottom of this graph, but it starts all the way back in 1997. And so this cluster here of 3 cases occurred between November of 2016 and April of 2017, and so it was very unusual. The other unusual thing was that each of these cases lived in a rather suburban area as opposed to most of our cases which live in more rural farming communities. So as a result of this cluster of cases, there was a lot of media interest and a lot of interest from the public, and that interest resulted in a large increase in requests for testing. So people would call reporting rodent exposure and nonspecific symptoms that could be indicative of prodrome, but they had not had any respiratory distress. And so You can see in 2015 and 2016, very low numbers of tests. And then in 2017 in blue are the numbers of tests that were requested. So we developed a screening process whereby if someone had thrombocytopenia or more severe respiratory distress symptoms, we would test them directly through public health. If they had viral prodrome symptoms and something nonspecific, we asked that they be tested through a commercial laboratory first. And then only if those commercial laboratory results were positive were they tested through public health. So you can see in orange is the number actually tested through public health. And so we were able to take a look at this data from all of this testing that was going on to assess what we were seeing with the commercial assay. And 13 out of 20 people were tested at a commercial lab before they were tested through public health. 8 of those ended up being false positives. So the majority of positive results from commercial labs were false positives. And if you look at the range in results here, so the IgM results were much lower on average for false positive cases than for true positives, so an average of 3.4 compared to an average of 8.8. And we never saw a positive IgG from a false positive case. So false positives always had IgG negative results at commercial laboratories. And then true positives had much higher IgM results and were much more likely to have an IgG positive at a commercial laboratory. So only one of our 5 true positives was IgG negative, and that person had a very high IgM positive. As I mentioned, all of the false positives were negative. Only one of our true positives had an IgM result that was less than 8.0, but the IgG was also positive, which allowed us to differentiate. And then we only had 1 false positive with an IgM result of greater than 3. The IgG was negative in this person, and cross-reactivity with EBV was suspected. So in conclusion, all rodent droppings or nestings should be treated as potentially infectious material. People should prevent rodent exposure. People who develop signs and symptoms of hantavirus, even viral prodrome who report rodent contact should describe that rodent contact to their healthcare provider and seek treatment and testing. But providers should never rely on a positive commercial result alone to diagnose their patient. That's all I have, and I'm happy to take questions.
Hello? Oh, it's on. Taking questions. Has anyone got a question for Hanna? Over here. Okay, Sunny.
Thanks for your presentation. Sunny, I'm a geographer at the BCCDC. Is there anything known with regards to associations of increased hantavirus activity and environmental conditions, such as droughts or heavy rains and so on?
Yeah, that's an excellent question, and that was a question we received a lot right after the cluster of King County cases, and we looked a lot into that. Part of the problem with delving into that relationship further is the very small number of human cases and the lack of mouse data. So we were interested in several different interactions there. So the weather could affect mouse population and mouse population size, or the intensity of contact within mouse populations. It could also change how humans and mice are interacting with each other, so are more mice being driven indoors, because we did have a really rainy winter this last winter, so we were really curious if something was going on there. So we talked about doing rodent sampling again, going out and looking at mouse populations in that area and potentially testing. And we had a lot of conversations with both CDC and with several experts around the country. And essentially the conclusion that we were repeatedly brought back to was that the interactions there are so complex, and the amount of information you would need essentially would span decades to understand mouse populations in a specific area, you need to look very focally at multiple different points because you might find a very concentrated mouse population in one area and 1 mile away you might find nothing. And so after having those conversations, we decided not to pursue any further look at that, but it's a very good theory that we have as to why this happened. We just don't have any data to prove it.
Okay, I think we have time for one more question if there is one. All right.
Hi, Aaron. Thanks very much. This is more not really a question for you, but maybe for Moorshed. So how often are we seeing clinical cases here? I mean, in BC, we saw a whole bunch quite a while ago, but my sense is we're either not seeing or not recognizing as much anymore.
I think that we are seeing cases, as you mentioned, this year we saw 2 cases from interior. And also that you brought a point that even the winter time, we thought that it is only the disease for summer, but I think that a couple of years ago that we found a case from Oltean, and during the winter, I think it's December or January, and that happened inside the house because that house was infested with deer mice. We get very few, like in some year we don't get any or 1 or 2 a year, but my personal thought that we are missing a lot of cases, especially those cases they survive. They come with GI symptoms and little bit distress and they get better and no diagnosis done. And the physician never sends a sample for hantavirus. So that does happen. On the other hand, our neighbor province, Alberta, their physician cohort are very good for identifying hantavirus cases. So their death rate is very low, but case number is high, and our death rate is high, but case number is low. So that means we are missing cases.
Great. Thank you very much. I think we'll stop the questions there so we can move on. Thank you, Hanna.